Assalamu alaikum, sabah al-khair jami'an. So it's my privilege to present about bone health in men. Here is the outline of my talk today. Briefly, I will touch base on the prevalence of osteoporosis in the kingdom and the concept of peak bone mass and the differences between men and women, and what is the role of androgens and estrogen in that, causes and risk factors. How can we diagnose, and we come across the challenges that we face in regard of T-score. What about in men also? So what are the indication of BMD testing also, and the evaluation treatment options that we have? So the first question is, how prevalent is the osteoporosis in men? So it has been thought it's a disease of women, but the data suggesting that over age of 50, men tend to have fractures also. Around 20% of men over age of 50, they will experience osteoporotic fractures. So that's quite common. And when we talk about the fractures in men, we know that around 20% of all osteoporotic fractures occur in men in comparison to women, of course. And not only that, but vertebral fracture almost half. So that's quite high percentage of vertebral fracture in comparison to women. And the most serious thing is the mortality following hip fracture. Men tend to die, around 38% of men will die in the first year following their hip fracture. And when we talk about the fracture rate in comparison to women, men to have bimodal distribution where they have a peak, usually at younger age, at adolescent and young adulthood. And why is that? Most likely because of trauma. But after that, they will experience an osteoporotic fractures later in their life, around 10 years lag behind the fracture in women. Talking about the data in the kingdom in regard of men over age of 50, if you can see the figure that, or the data that has been presented by Prof. Sadat around 10 years back, where they recruit in this meta-analysis more than 800 patients of men. So it's around 46 of those subjects were osteopenic, and 31% were in the osteoporotic range. Only quarter of them were in the normal range. That's of course, has its own limitation regarding the higher prevalence of, let's say, vitamin D deficiency that we can't differentiate, other chronic diseases, and being in tertiary hospitals. What about, that's in regard of DEXA scan. What about fracture data? Again, here around 13%, they will experience vertebral fracture in comparison to women where they have around 20% vertebral fracture risk. So that's in regard of fracture at the vertebrae. What about hip fracture? It's already mentioned earlier by Prof. Saleh that tend to have higher prevalence of hip fracture as we are getting older, but the data in comparison to the international figures are less. We'll have around 7-fold increase in the risk of hip fracture in the kingdom by 2050. So that's the estimate. So the most interesting part in the differentiating between men and women is how they achieve the greater bone mass in comparison to women. So men tend to have a big bone mass that occur at around age of 20 to 25. They will reach it with increased in comparison to women by around 10%. They will not have the drop that we've commonly seen in menopausal status in women, so they will have a slow decline that we observe in men in comparison to the significant decrease that's occur usually after menopause in women. With the changes that occur with the aging, men tend to have, they will lose both gender actually, they will lose the cortical bone thickening, but men, they will compensate that by increasing the diameter and the deposition of that. So the diameter or the cross diameter, it will be increased in comparison to that in women. What about trabecular bone? So men, they will have loss of the, or women, they will have loss of the trabeculi and also thinning of the trabeculi, predisposing them to higher risk for fracture. But men, they will have only thinning of the trabeculi, but they may preserve their trabeculi numbers. So with all of this, so men tend to have lower fracture risk because if they achieve greater big bone bounce, bone size in comparison to women is larger, greater muscle mass in general with the effect of androgens that we'll be talking about that shortly. They will have more activity in general, and absence also of menopause that might contribute largely to the decline that we've seen, and a shorter life expectancy based on the data. The most important part is the effect of androgen and estrogen in achieving that, and we'll be talking about testosterone that we commonly know, or we know that testosterone commonly converted to estradiol by the effect of aromatase. So what will happen in that? So both estradiol and testosterone, with the age, things will start to decline gradually. But what is the effect on bone? So, and it has been found that the estrogen has the prominent or the dominant effect on bone remodeling in men also. And I was discussing with Prof. Mona Foda last week about learning from the rare diseases that will lead us to better understanding of osteoporosis in general. So if we talk about the testosterone and conversion to estradiol, just imagine if you don't have the aromatase in men, what will happen in that? And also if they have like estrogen receptor insensitivity or blocking of the estrogen receptor in men, what will happen? So in these cases where they have a gene knockout at the level of the receptor or deficiency in their aromatase, what will happen in those kind of patients? They will have androgen levels that normal or elevated in case of estrogen receptor knockout, or deficiency also in regard of estrogen if they have aromatase deficiency. So bone density tend to be very low in those kind of patients. Around 8 cases overall, it has been described in the literature. They have very low bone density. And also the interesting part, if they are receiving low dose of estrogen, what are the outcomes? So their growth spurt will stop. This picture is for a 27-year-old male where he kept growing because they don't have estrogen to stop them or to close their epiphyseal. So epiphyseals will close, bone density will significantly improve, and also the habitus and lipid profile will improve in those kind of patients. So moving to the factors, it's almost similar to that in women. But keep in mind there are causes, primary, that's age-related or idiopathic. And in men, you have to keep in mind the secondary causes of osteoporosis. Almost half of the cases is related to osteoporosis, and men tend to relate it to secondary causes. So we have to look for secondary causes in men. So what are the secondary causes? We tried to summarize this based on the general lifestyle measures that we have, and also the list of medications that we have or commonly seen in women also, and long list of diseases that might contribute to osteoporosis in men also. The majority of them: alcohol use, glucocorticoid, exogenous glucocorticoids, and hypogonadism that will be addressed shortly. We've discussed earlier the challenges behind DEXA scan and using T-score as a diagnostic or a treatment threshold. So what about the challenges in men? What should we use? Are we comparing the T-score to the male reference database or to the female reference database? So that's quite challenging. And men tend to have higher size dependent. So we know that the DEXA scans highly size dependent. So the diagnosis might be underestimated or overestimated in comparison to that in women. But most of the studies, they compare the T-score in comparison to the male database. So that's one of the challenging that has been faced in regard of diagnosis of osteoporosis in men. But the recent guidelines suggesting that to use a female database as a diagnostic threshold for men also. And why is that? Because both men and women, they will have an absolute fracture risk, or they will fracture at the same absolute BMD values rather than T-score. So it has been recommended to unify that. We will use a T-score of minus 2.5 in men and also in postmenopausal women, men over age of 50. Of course, if you have osteoporotic fracture, that will be equivalent to osteoporosis, and that's one of the indications for initiation of therapy in those men who has osteoporotic fracture. And FRAX, the interesting part about the FRAX that we have discussed earlier, what about its validity in men? So the original cohort of the FRAX, it's around 20 to 25% of this cohort, they include men, so that's quite representative, and the comparison, it's almost similar to that in women. The Saudi FRAX that has been published by Prof. Saleh, so it's around 43% of those cohort were men. So it's quite representative, and we can rely on the FRAX also, not only in postmenopausal women or men or women over age of 40, but also in men. And we've discussed that earlier. The same apply in men, that if you have a clinical risk factors, so your ability to predict future fracture in men will increase significantly, not only based on the T-score, but other clinical risk factors. So it has been published in regard of Endocrine Society that using a T-score as a diagnostic threshold, T-score of minus 2.5, as we discussed earlier, and it's almost similar to that women. We will have a brief talk, or we'll have a talk about glucocorticoid-induced osteoporosis. So having also glucocorticoids of high-risk group, that will be an indication for definition for osteoporosis, osteopenia, and high FRAX also. So in regard of screening, it has been mentioned earlier that you have to calculate FRAX. So that's the new or shift that has been suggested, that you have to do FRAX and you can include clinical risk factor. Then you can decide whether this patient will go for BMD testing or not. If you are going with the North American guidelines, that they rely mainly on the age. If you have a male who is over age of 70, to proceed with that. And if you can take this as a clinical risk factor age, so over age of 70, it has been recommended in different guidelines. Having also fractures over age of 50, so that will allow you to proceed with the BMD testing after doing a FRAX. And also if you have vertebral abnormality on the X-ray or osteopenia, it has been suggested to proceed with the BMD testing. List of medication or diseases also that you have to keep in mind that has a risk factors for bone loss and osteoporosis. Here is the new guidelines, or the new suggestion that has been addressed in regard of Endocrine Society to 2012 over age of 70. But the latest one was the International Clinical Densitometry Guidelines. So if you have a male over age of 70, it's better to proceed with the BMD testing if a clinical risk factor is there. If you have a vertebral fracture, it has been suggested also, even by the Saudi guideline that has been discussed early in the morning, that whenever you have the possibility of having vertebral fracture, proceed with that, especially in those who are having kyphosis or men over age of 80. It has been recommended by the International Society to proceed with that, having a vertebral fracture based either by a DEXA scan, or you can proceed with the thoracolumbar X-ray to rule out vertebral compression fractures. In regard of labs, it's almost similar to that in women, but I would like to highlight that if you have a male, so consider ruling out the secondary causes, and this is the message that I would like to deliver. In osteoporosis in men, you have to screen for secondary causes, and one of the screening tools or the blood test that you can do also, there's the testosterone, early morning testosterone, and you need at least 2 readings to confirm the diagnosis, in addition to symptomatic hypogonadism in those kind of patients, and we'll come to that shortly. What about bone turnover markers that we've discussed yesterday? So bone turnover markers based on the Mr. Oz study, which is the largest epidemiological studies in men where they recruit around 600 patients. If you have a higher bone turnover markers, bone resorption markers, that will help you to predict the future fracture and bone loss in those kind of patients. And we know that there are some limitation in bone turnover markers, same apply in men also, lacking of variability, and also not using as a diagnosis or a treatment initiation in regard of bone turnover markers. When to consider initiation of therapy, if you go by the UK guideline that has been published recently, they specify that or they stratify patients according to their fracture risk, similar to that in postmenopausal women. So if you have a male over age of 50, so you classify if they have high risk for fracture or very high risk for fracture. It has been recommended to initiate the therapy, but if you have those who's in the intermediate fracture risk, so it's better to proceed with the BMD testing, and you can decide after that for therapy. The North American guidelines still, it's almost the same in regard of recommendation. It's not limited to this, but including the fractures, T-score of minus 2.5. But keep in mind that a T-score alone is not an indication based on the recent data that we have to include other clinical risk factors, of course. Long-term glucocorticoids, and has been mentioned that having a 7.5 milligram of prednisolone or its equivalent for a duration of 6 months or more, it's an indication for initiation of osteoporosis therapy in men. Here is the list of approved agents. Just to highlight, the abaloparatide has been approved around 2 months back for osteoporosis in men also. So what you will do in case like in prostate cancer where they are receiving androgen deprivation therapy is to consider 2 classes of therapy, bisphosphonate, mainly zoledronic acid, and also denosumab. Teriparatide in those kind of patients will be contraindicated based on the history of radiation therapy and active malignancy. Romosozumab is not well studied in those kind of patients yet. Abaloparatide is similar to teriparatide. In male with hypogonadism and hypogonadism symptoms with very low total testosterone level, it has been suggested to initiate testosterone, and it has been thought that testosterone injection might help to in regard of BMD gain that observed with the testosterone therapy, mainly the injections. Briefly about those medications, so we have first zoledronic acid. They have largest data in regard. They include around 1,200 male patients, either with the hypogonadism-associated osteoporosis or with the primary osteoporosis. And that was the first clinical trial where they include fracture data. If you look at the BMD gain, it was significant at lumbar spine. In comparison to a placebo, it's almost similar to that in women, but the most important thing also is the fracture risk reduction, vertebral fracture, and after 1 and after 2 years of therapy was significantly lower in comparison to placebo group. So that was reassuring. What about alendronate? It's almost similar, the meta-analysis showing some benefits in regard of vertebral fracture, but was not with the non-vertebral fracture. In regard of denosumab, the study that has been published where they include a high-risk group, men, 24 months, denosumab was given at 6 monthly in comparison to placebo, then the placebo group crossed over to another dose of denosumab. So what happened? The BMD gain was observed and significantly increased, and also the total hip was observed. It's almost similar to that in women. So again, the data reassuring in regard of using denosumab as a treatment option for osteoporosis in men, mainly over age of 50. Similar bone suppression and bone formation markers that has been suppressed with the denosumab. Moving to the anabolic therapy, we have the teriparatide, and we got almost similar BMD gain at the lumbar spine and not with the hip as we are expecting with the teriparatide. It's almost similar to that seen in women. Moving to the new therapy that has been approved, as I mentioned 2 months back, abaloparatide. Their data was published recently where they include abaloparatide around 225 subjects. So after the therapy of teriparatide, 1 year of teriparatide, what happened in regard of BMD? There was a significant BMD gain, not only at the lumbar spine, but also at the total hip and femur neck, but was not significant at the radius area, as we are expecting with the BTH analogs. Romosozumab, it's a promising agent regard of anabolic effects and less anti-resorptive effects in regard of being also the bone turnover markers. It has been studied in men, and as you can see here in the figure, a dramatic increase has been observed with a 1 year of therapy that's reached up to 12%. It's almost similar to that in women. Total hip gain, femur neck also, but keep in mind that there was an imbalance in regard of possible side effects in regard of cardiovascular outcome. It's also observed in men, around 8 cases in comparison to 2 cases that has been observed in men. So moving to the testosterone. So if you have a patient who's having hypogonadal symptoms, what to do with those kind of patients? So testosterone has been used in those kind of patients with having low BMD and also hypogonadal symptoms, based on the studies that the testosterone injection improved the BMD at the lumbar spine. It was not seen at the hip area. So we have to discuss and to address the balance between the benefits and the possible side effects that we observe in general, improving the hypogonadal symptoms, muscle strength, and also the BMD gain that we observe in general. And we have to keep in mind the possible side effects with this testosterone injection, that including prostate cancer and increasing the risk of metastatic prostate cancer, heart failure, or worsening of their obesity, sleep apnea. It has been recommended by the Endo Society, if you have a male with a high fracture risk, don't depend on testosterone alone, but you have to add another anti-osteoporotic medication with a proven efficacy in terms of anti-fractures. But if you have a borderline high fracture risk, moderate to low, you can consider treating him with the testosterone alone. Of course, if you start testosterone without significant improvement in their symptoms, it has been recommended to discontinue the testosterone. Yes. So here are the summary of the clinical outcomes regard of BMD gain that we've discussed earlier. So alendronate, zoledronic acid, denosumab, teriparatide, and abaloparatide. You can see these improvements in regard of BMD gain. We have some fracture data that's reassuring, but it has been recommended or it has been authorized to be used if you have a BMD gain and also bone turnover marker that's similar in women. Romosozumab will have a BMD or the bone turnover marker that increase with the less effect on the CTX marker or bone resorption marker. Testosterone, we don't have the fracture data, but some gain that observed with the lumbar spine BMD. So to wrap up, we have the osteoporosis that's common. We have to deal with that, and we have to look. It has been under-treated and under-recognized condition in men. Look for the secondary causes in general, and the diagnosis by either by presence of fracture, BMD testing, or HyFrax. And it's almost similar treatment as we've discussed in postmenopausal women. Consider testosterone injections for those who's having hypogonadal symptoms. With that, I will conclude. Thank you all.